Thank you everybody for joining this webinar today in our series of webinars from the European Observatory on Health Systems and Policies. And today we have a very important topic, namely improving access to health promotion and preventive services for vulnerable children and adolescents. This is also a policy brief that we recently published and that you can also download. It will be in the chat later on, so you can download it yourself and read it at your own time. My name is Ewout van Ginneken and I'm moderating this webinar today with the help of Eriksen and also Beatrice Duvy. They are helping me monitor the chat. As we all know, children's health is crucial in shaping the long-term health of development and well-being of children, and especially children that are at risk of poverty or social exclusion have higher needs, but they also face the greatest barriers. So this brief really focused on, how can we reach this particular vulnerable group of children and young adolescents? So in this, action-packed webinar, we want to discuss the following questions. How can we improve access to health promotion and preventive services? And also, what are the lessons that we can learn from each other? We want to do that together with a whole host of speakers today, and the first one giving the keynote is Astrid Eriksen from the Berlin University of Technology and the Berlin hub of the European Observatory. And she will be followed by Karen Bode, who is the Strategic Youth Policy Advisor at the Association of Regional Health Services in the Netherlands, and she will talk about developments in the Netherlands and online platform that helps parents and their children. Then we will hear a perspective from Portugal, from Tanya Kaspar, who will talk about the policy cycle that they use and approach vulnerable children. And then we will hear from Germany, from Adrienne Aleli. She's the Deputy Head of Child Health Services at Heinrich Heine University in Düsseldorf, and she will talk about the childhood houses in Germany. Then we will have a comment from Damiano Constantini, who coordinates the health of children and adolescents within the Federal Office of Public Health in Switzerland. Then we will have a Q&A with all of you, hopefully 20 minutes, and we will finish also with a reflection from WHO, from Natasha Azzopardi-Muscat, who is the Director of the Division of Country Health Policies and Systems at WHO. And she will talk about the children's health and well-being strategy that WHO is developing together with UNICEF. So a lot to go through, and so let's start and ask Astrid to give her keynote. Astrid, the floor is yours.
Thank you, Ewout. I'm just pulling up my slides and asking if you can see the correct version.
Yes.
Perfect. Thank you. Good afternoon, everyone, and thank you for joining our webinar today. My name is Astrid Eriksen, and I'm based at the Technical University of Berlin, which is one of the two research hubs at the European Observatory on Health Systems and Policies. And in the next few minutes, I will provide an overview of some of the key findings from our recently published policy brief that Ewout mentioned on improving reach and access to health promotion and preventive services for vulnerable children and adolescents. And I will do this on behalf of the co-authors, some of whom I'm joined by today and that you will hear from later. So, why did we write this brief? Children and adolescents represent our future. In 2023, young people in the EU aged under 19 represented 20% of the population. However, in the same year, an alarming 25% of children below 18 years old were at risk of poverty or social exclusion. Children from disadvantaged backgrounds have higher unmet needs and worse health outcomes. All at the same time, childhood and adolescence are pivotal stages in shaping long-term health, development, and well-being. And ensuring equal health opportunities is not merely a matter of immediate concern, but crucial for preventing future health issues. The commitment to investing in children and adolescents is echoed in the agendas of many international organizations. One example is the UN Convention on the Rights of the Child that has been ratified by every country in the WHO European region. However, despite these commitments, countries do not invest enough in prevention, with countries allocating significantly less of their health spending to prevention compared to other areas of care. At the same time, there are multiple barriers stopping vulnerable children and adolescents from accessing support, including costs, administrative complexity, the fragmented links between sectors, language, and health literacy. So with this context and situation in mind, we wanted to examine how 5 selected European countries have implemented innovative ways to improve vulnerable children's and adolescents' access to services. And we specifically aim to answer 3 policy questions. The first is, how do countries enhance horizontal collaboration, which is collaboration among various governmental departments and sectors, and vertical collaboration, which is collaboration across different levels of government. Secondly, we wanted to look at how countries are bolstering data collection and information sharing between and across different system sectors and settings. And thirdly, what outreach efforts could boost the uptake of available health promotion and preventive services for vulnerable children and adolescents. So, health promotion and preventive services for children and adolescents are frequently dispersed across various sectors, and they involve several stakeholders. And this wide range in diversity can create challenges in achieving effective cooperation. So with this first question, we wanted to examine how countries try to enhance the collaboration. And here we saw that countries are establishing national prevention strategies and programs to improve coordination of health promotion and preventive services within a multi-actor operational environment. And one example of this is the Healthy and Active Living Agreement in the Netherlands. Secondly, countries are also creating integrated regional or local networks for delivering services. And one example of these are family centers in Finland, which have been around since 2002. Thirdly, there are also examples of countries establishing integrated multidisciplinary child and adolescent health service programs, which we have an example of in a policy brief from the Netherlands. And then there are also initiatives to set up interdisciplinary and interdepartmental contact points for addressing suspected cases of child maltreatment and violence. And here we have an example from the childhood houses in Germany. And finally, we saw examples of using designated navigators to assist children, adolescents, and families in finding the services they need in an often complex system. And with the second question we wanted to examine was how countries are bolstering data collection and information sharing across different sectors. And here it became clear that while most countries in the WHO European region routinely gather and analyze data on the impact of interventions by sex and geographic area, the practice of breaking down data to reflect the situation of specific groups is far less common. And this detailed and disaggregated data collection is key to identifying the needs of vulnerable children. Then we saw that many countries collect data on the well-being and lifestyle of children and adolescents in schools. And this is important for evaluating health promotion activities and refining planning processes. However, there is scope to improve data collection for vulnerable groups of children and adolescents. And although many countries employ national surveys, there is room to improve the data collection while preserving anonymity. And one example is Finland, where there are efforts underway to expand the school health promotion survey to include detailed data on children and adolescents in vulnerable situations. And the collection of data needs to be clearly and systematically connected to strategic public health decision making. For example, in Germany, data on school children's health are collected via municipal public health services during the school entry examination. However, the data is not fully digitalized and only partly analyzed, and therefore have limited impact on policy change. And finally, the challenges in data accessibility can hinder evaluation. So while there are efforts to collect data on vulnerable groups, they often face challenges regarding nationwide implementation and the granularity of data analysis. And finally, we examined some of the outreach efforts countries are implementing to boost the uptake of available services. And here, countries are using, for example, digital services and platforms, and these can offer valuable resources for children, adolescents, and their families to access information about what services are available. However, there are some challenges to keep in mind, and that is there are large differences in digital literacy, and it assumes that people use these platforms and that information is understandable. Secondly, we also saw examples of targeted communication campaigns, which can raise awareness among the targeted population about rights and available services. Thirdly, we saw examples of dedicated support for parents, caregivers, and families in vulnerable situations. Parenting and caregiver support aims to engage parents in activities that enhance their awareness, knowledge, and child-raising abilities. One example is the early prevention in Germany, which offers, among other things, support for expected parents and families. And finally, school health services provide an important opportunity to reach vulnerable children and adolescents. They play a pivotal role in connecting with children and adolescents in general, as well as vulnerable groups, and they are strategically positioned to provide preventive interventions and facilitate access to care. And one example of this is the National School Breakfast Program in the United Kingdom that is delivered through schools. So what did we learn through these case studies? We learned that by prioritizing the following interconnected strategies, policymakers and stakeholders can work towards closing the gap in health disparities and ensuring that every child has the opportunity to achieve optimal health development and well-being. The first is enhancing strategic collaboration across sectors and stakeholders. Cross-sectoral collaboration is essential for the effective delivery of health promotion and preventive services. As health promotion and preventive services are dispersed across various sectors and implemented at multiple levels, it is necessary to reduce the complexity of systems for fostering a holistic care approach. And stimulating bottom-up approaches in delivering services can expedite the scaling up of innovative programs. Secondly, we need robust data collection and sharing infrastructure. The use of data and information sharing across sectors needs to be strengthened in order to guide policy development and building capacity. Systematic collection of national data on vulnerability is crucial for understanding the needs and designing targeted interventions. And integrating health data with program evaluation is crucial for effective decision-making. And thirdly, targeted outreach initiatives should be clearly tailored to target groups to increase the uptake of health promotion and preventive services. So, thank you very much for your attention, and that was it from my side, and I look forward to the discussion.
Well, thank you very much, Astrid, for this very concise and very clear overview. All the examples you gave are directly from the brief, so you can find them there, the boxes that you showed. Let's also, if you have any questions, please put them in the chat. Erica and Beatrice are monitoring the chat, so we look forward to your questions. Let's now go to Germany, to Adrienne. Adrienne, the floor is yours. Look forward to hearing from Germany.
Yeah, thank you. I would like to share a spotlight on the childhood houses in Germany, which is still a relatively new service that we have in some of our federal states. It is an interdisciplinary, interdepartmental point of contact for children who have been a victim of sexual abuse, physical violence, or severe neglect. And in the childhood houses, children can receive different types of services, with the purpose of tertiary prevention. So the purpose is mainly to reduce re-traumatization through reducing the number of contacts for questioning. As you can see in this picture, this is an example of the childhood house that we have in Düsseldorf. So you can see there is a room with cameras which provides the opportunity to record forensic interviews and thereby reduces the necessity for children to speak in front of court. So these recordings can be used in court. As you can also see in the picture, there is not only forensic interviews that are conducted in the childhood houses, but a number of other services as well. So there are healthcare services provided, diagnostics, psychological support, but there are also other professionals that come together in the childhood houses. And this sort of takes up one of the policy strategies that have been identified in the policy report, as it brings together stakeholders from different societal sectors, as you can see here, the police, the healthcare sector, youth services, and the justice system. At the moment, we have 11 childhood houses in Germany, and there has been the intention to roll out those services by different states. And recently there is a new development. So we just have, as some of you may know, we have a new government in Germany. And on April 14th, there has been a new coalition agreement where the government expressed an intention to establish federal level funding for the childhood houses. And I think that is really great news, given the fact that currently all childhood houses are implemented on a project basis. So they are not routine care yet. And maybe for you as an international audience, that is interesting that the childhood houses in Germany are based on international models. So there are other countries that have similar models, but there are called Barnahus, for example, in Scandinavia, and in countries like, for example, the United States and Australia, these similar models are called child advocacy centers. Yeah, thanks for the opportunity to share this example. Looking forward for your questions.
Thank you very much, Adrienne, and we will certainly have questions for you in the chat later. What a great development to see these houses now popping up in Germany with support from the government. Great model, internationally tested. Now we're going to Portugal, to Tanya. So Tanya, please talk about the policy cycle in Portugal.
Hello, everyone. Thank you very much to have the opportunity to be here. I'm going to present the cycle of policy that to use in order to integrate the work that we can do. So, as you can see, this cycle includes that we have to have evidence base in order to build and prioritize the intervention. Afterwards, with this data, we develop in the intervention, but we also training the professionals and also develop some manuals or publications in order to disseminate this practice and work with the public policies and government in order to this kind of good practice can use like a program in national programs and also international programs. So after we study these policies and these programs in Portugal, we can use, and normally we can use like a project we have teams for other countries. So one of the examples of evidence-based is health behavior school children. It's a study from Health WHO that is developed in 51 countries, and you use in Portugal this data in order to identify the specific needs of children with the disadvantaged children, like migrant children, low socioeconomic foster care children, and rural children. So when we have our data, we achieve that these kind of children, they have higher risks in several contexts. They have less mental health, like they have more psychological symptoms, they have more situations of violence, but they also have a better relationship with the teachers, they have more school failure, and they have more alcohol use, self-harm, and so on. So they have the double situation of risk. With this data, we're going to develop and create national programs. I gave here two programs. One to migrant youth, Be the Change. It's with the migrant youth, and we develop with them how they can contribute to the society. So we develop with them like a parliament. They decide what they want to do in several areas for their well-being and their contribution to that. Another one, it's at Teu Lado, it's at your side. It's a program to children that they are victims of domestic violence. With these programs, we implement the programs, we develop a manual. So we have a manual to Be the Change and to a Teu Lado. And these manuals can be used for other institutions and other professionals for whole country. And we also develop some scientific publish, and also with social media in order to achieve all the population and do some health literacy to the global population. Finally, we work with the health ministry and the education ministry in order to use this data, evidence-based data, and also the intervention in order to develop some programs to all country. For instance, our team are working with the health ministry in the national program for health at schools, and we also develop a work with the border of psychologists about the mental health of the youth. And with the project at Teu Lado, we develop a special group of work in health ministry, social ministry, and education ministry in order to work together to help these children because we have like 300 children that have violence at home, and it's a very hard problem for their mental health and for their future. So we use this cycle of policies in order to do our intervention. Thank you very much.
Thanks so much, Tanya. And I like the systematic approach and the use of the data. Already I saw questions popping up that we'll get to later, I guess. How then do you use that data to identify those vulnerable populations? But before we do that, first we go to the Netherlands, and Karin, asking you to talk about the developments in the online platform in the Netherlands. And you maybe also have a bus for us, is that correct?
Yes, I'm happy to share with you two examples from the Netherlands. My name is Karin Bode. I work as a strategic advisor, and I'm working at the Dutch National Association of 25 regional health services. And in the Netherlands, we have a unique system. We normally see the children in consultation offices in the neighborhood. So we have over 400 of them in the whole of Holland. But with children in asylum seeker centers, it's a different case. So we have 100 regular asylum seeker centers, but over 200 emergency locations. And as you can understand, there's a total lack of space. So there's no space for our youth doctor or our youth nurse to examine the children. And that led to some creativity. So we have our own bus, our public health care bus for the youth. And you can see it on the picture. You get in the middle of the bus. There's a waiting room. And at both sides, to the left and to the right, there are examination cabins. The left is for the nurse and for the right is for the doctor. The nurse does the intake and gives some vaccinations, and the doctor do the medical examination. In this way, it's possible to see the children within a span of 6 till 10 weeks, because that's what we have to do. We have to see these children as quickly as possible. And as you can understand, the bus can drive to different locations. So it's going up and down in Holland, and every other day it's at another center. In Corona time, in COVID time, we have used this bus for special vaccination campaigns. It was able to drive up to neighborhoods where people wouldn't come to our vaccination locations. And in this way, we were able to go to the people, reach out, and get them some vaccinations. The other example I want to tell you about is on the next slide, and that's about our online platform called Growth Guide, or Groeigids as we say in Dutch. And all our 25 regional public health services uses this information to inform parents. So they invest in it. We have a website, we have an app, we distribute newsletters, and we also have a paper booklet. And in a very easy way, parents can look for reliable, independent content. That's very important. And in the app, they can also highlight milestones of their children. They can add up some photographs, and they can easily share it with family and friends. The booklet in paper is also important because some people rather write it down and bring it with them if they come to our offices. And it's written in rather simply language, B1 level. We use a lot of illustrations, and we also use short movies to explain different topics. And to distribute it, we use social media platforms like LinkedIn, Instagram, and TikTok. LinkedIn for the professionals, and Instagram and TikTok to provide parents for information. And one unique thing is that parents can chat with our youth nurses. So if they have questions or concerns about their child, they can just get into a special place, click on a button, and then they can ask questions to our youth nurses. These youth nurses just log in from home or from the office, so they can reach every parent in the Netherlands. And we have about 5,500 chats per month. It's not only during office hours, but also some evenings during the week they can reach these youth nurses, and it helps to be outreaching and also reach these families and children in vulnerable situations. I think my time is up, so I'm wondering if you have any questions later on.
Thank you very much, Karen. And I'm sure there will be questions on these two very concrete examples to reach vulnerable groups by buses and online platforms and social media. Now we're moving to Switzerland and to hear from a policymaker perspective. So Damiano, I'm asking you to give to discuss what we've just seen. And Damiano was also instrumental in this policy brief because he was the person who also helped commission this brief and that we worked on all together. Damiano, the floor is yours.
Yeah, thank you, Ewout. The Federal Office of Public Health in Switzerland has indeed commissioned this policy brief because despite offering high quality services in our regions, we still struggle to reach children and adolescents in situation of vulnerability. So Switzerland has 4 official languages and a federal structure with 26 cantons. This allows for diverse services adapted to the needs of the local population in cities and in the remote mountain regions. It also makes for a certain fragmentation. This means that there is no one solution to fit all cantons to better reach children and adolescents in situation of vulnerability. This is why we wanted to learn from other countries. How do they tackle the problem? How are there different approaches? So we are very thankful to our colleagues from the Netherlands, Portugal, Germany, but also Finland and the UK for sharing their experience and knowledge. It is really helpful for us. But I'd like to use this opportunity to remark on one of the conclusions of the policy brief I find particularly important for Switzerland today. We are now facing cutbacks at the federal level in several ministries. Similar cutbacks might become a reality in some of the cantons. The conclusion that cross-sectoral collaboration between education, health, and social systems is essential for the effective delivery of health promotion and preventive services for vulnerable children and adolescents is, for me, a crucial one at this moment in time, because with cutbacks, we are generally required to focus on essential tasks, often at the expense of cross-sectoral collaboration. We should instead consider that for effective delivery of services with less funding, we might rather strengthen our cross-sectoral collaboration to better reach children and adolescents in vulnerable situations. So this is what's at the moment really also is a new challenge for us in Switzerland. How to do better with less money and less resources. Thank you, Ewout.
Thank you very much, Damiano, and I couldn't agree more how important under the current circumstances that is to keep investing into children's and young adolescents' health. Now I would like to ask all the speakers to come online again and show themselves so that we can start our Q&A. So Astrid, Tanya, Adrienne, Karin. And now I'm also going to my two co-moderators, Erika and Beatrice, I don't know where I start. Do I start with you, Erika? And to tell us what happened in the chat.
Okay, so if you start with me, and then Beatrice can do the next round. Hopefully we have time now for 2 rounds of questions, because your timekeeping has been impeccable, everyone. Thank you very much. So one question is on the parameters of the policy brief, which is probably a question for Astrid, really. But it's, were children with disabilities included in the vulnerable umbrella? And do we mean sort of primary or secondary prevention when we're talking about prevention, preventive services? So just a couple of sort of like more definitional questions. But then some sort of like bigger questions about the wider topic area, which would be for all the panel, which is how do you use these data to identify vulnerable children? So how do you combine different data sets? How do we get data on younger children? Because for example, the HBSC is from age 11 onwards. And then just one third one, how do we get all these innovative programs integrated into things like the EU mandated national action plans? So what is the role for transnational actors such as the EU or WHO in pushing this agenda forward? And then we'll come back to the next round with Beatrice after this. Thank you very much.
Thank you, Erika. So maybe we start with you, Astrid, and maybe you can start to answer those first questions on the scope of this piece of research.
Yeah, I'm happy to. So for the first question, in terms of is children with disabilities included in the definition that we're using in the policy brief, the short answer is yes. We look very broadly at how we are defining children with and adolescents with vulnerabilities. In terms of the second question, we do focus mostly on primary and secondary prevention, but there are also examples of tertiary prevention, as we saw with the childhood houses. And we do have, as we saw with childhood houses in Germany, and we do have a whole box on definitions in our policy brief, where I invite the audience to go also to have a more closer look at how we define vulnerability.
Yes, we cast a very wide net. So the data question is a really relevant one. I don't know, maybe, I know that it came up also during Tanya's presentation, but maybe also Adrienne, you can start if you like, and then we go see if the others have an input.
Sure. I mean, the question was also about combining data. I have to admit that in Germany, we are not really good in combining data from different sources. But maybe I can say something about how can we identify children in need at an early age. I mean, we spoke about examinations in schools. That is definitely something that we have Germany-wide established, but there are certain pockets of cities where they also do similar examinations in daycare centers. So that's already a little bit earlier. And then there are those early prevention initiatives, which Astrid mentioned briefly in her presentation, which are, they include different activities, but for example, also people visiting directly after a new child is born in the home setting in order to identify potential risk factors and connect the family with appropriate services.
Thank you. So in Portugal, we saw that you really start with the data, Tanya. So maybe you can tell a little bit more, because then immediately a question came up, I saw,
Yes,
from the
so
audience, how do you use it then? Well, how do you then? Go ahead.
Yes. Okay, so we have this study, HBSC, it's from 11 to 18. But we also have the Observatory for Health and Wellbeing at school. It's from 5 to 12. And before of that, we have the health ministry, where the children before born until 5, So we have data from different observatories, but they all have data for all ages. And also we have the Observatory for Healthy Learning Environments in Participation, that is the youth that are at university. And afterwards, we have the Portuguese Lab for Healthy Workplaces, that is a study for people that are working, And we also have the studies for retired people. So we have studies along the cycle of life. And we recently published a brochure for health ministry, where we studied the health literacy since 5 years old and until death, the perception of health literacy and the relation of health literacy with mental health, health behaviors, social support, and environmental health. So we have, fortunately, all this data. What we try to do, our team work with the ministries, the health ministry, the work ministry, the education ministry, and the work labor ministry, and the just ministry. So we try to work with them, all of them. It's not easy, not for our perspective, but from their perspective, because I don't know, they want to how can I say, they want to do their mark, the main mark, and it's very hard to work with all of them at the same time. But we are doing some work together, and I think this is the way, as Damiano said, the way it's work with this kind of these departments, because when we have children at risk, we have problems with the social ministry, with the education ministry, with the justice ministry, with the labor ministry. So in order to help these children, we really need to work with all these ministries.
Yeah, and with that, you're already providing a very nice segue in the third question that Erica posed to us, which was about how do we get those programs better coordinated nationally, but also internationally. And I think internationally, WHO perspective, we will hear later. But perhaps Karin and Damiano can come in here, either talk about the data or perhaps how you try to integrate different services and between the different sectors. So maybe Karin, you go first?
About data integration? Well,
you can, whatever you want to talk about. It's either whether it's about the data integration or how you bridge between the different sectors in the Netherlands.
Well, we also have, we are monitoring our children. So we have these data, and we make like profiles from school, from neighborhoods. We can explain how children if they are vulnerable, if this neighborhood is vulnerable, or what kind of problems are there in schools. And that's the way we can advise about actions to take or policies to adjust. But I don't know if I am answering,
No, you are answering the question.
Something else?
No, I mean, maybe you can talk a little bit about how you in the Netherlands try to, bridge across the different sectors like schools and the health sector, social sector, housing, etc.
Yeah, I think our public health nurses and doctors have a very crucial role to in bridging all these domains. We have a social domain, a medical domain, and they are connecting.
navigating?
We are located in schools. We have contact with our medical doctors in hospitals or what's a huisarts called? General practitioner?
Yeah, GP post.
GP posts, yes.
Yeah.
So in that way, yeah, the collaboration between the sections sectors is very big, large.
Okay,
Yes.
so you're using the GP post and the nurses in a very crucial role. Okay, so there's a different approach in each country then. Damiano, I remember from visiting Switzerland that it was a huge challenge in the Swiss system with the cantons and the fragmentation to organize. You want to comment on that, or what steps you may already have been taken to integrate better between the different sectors and levels of government?
Well, from your question, I could only say we're not really active on this level because it's not our competency. It's all these activities are in the responsibility of the cantons. They have their own laws and they have their own services, and it allows really to tailor the services to their needs, which is quite important. But it's also is not really possible from top down to intervene.
Yeah.
And it makes also no sense. So this is exactly why we wanted to look at different approaches to actually give different perspectives to all the different responsible people who are responsible for education and social services and health in the canton. So which we think about 3 different instances in 26 different cantons. So it's quite a diversity that's
quite
going
a
on.
challenge. Yes.
And still intervening from the top on this level, it would probably destroy more than really be helpful, because they have different laws and also different professionals that are actually already working. So that's why this policy brief is so useful to us, because it allows us also to look at the data question. We're not particularly strong in the data question, and we are trying to get better. We are monitoring now the health of children, and we are working on better indicators. So it's a slow process, but I'm really hopeful that we can inspire people in the cantons to take action.
Right, so it's really more creating the environment, giving the data, giving the research, helping, setting up mechanisms to coordinate, but in the end, it needs to come from them. I think it's
Yes.
probably a challenge in many of the countries in Europe, actually. Thanks. Let's go for a second round. I know, is Beatrice also monitoring? Beatrice, can you come and
Yes.
tell us what else we are hearing in the chat box?
Yes, sure. Thank you, Ewout. So we received more questions. One about how to make the case beyond the health sectors for the co-benefits of poverty reduction or reaching vulnerable children across their life course. We also had another question about those services and how do we pay for these services. And also asking how do we best organize medical services specifically for asylum seekers. So I hope we'll have time to answer this question, and back to you, Ewout.
Yeah, what I'll do is I will just ask our panelists to answer the question they would like to answer. So maybe I can just start again with Astrid. Astrid, would you like to come in on any of these?
I would maybe ask someone else because I need to have another think about it.
Sure.
Yeah.
So let's go to Adrienne. So the questions were about how to make the case also outside the health system, the co-benefits of these policies, which I think are very obvious for children. I think it's actually a huge opportunity. And the other one was, how do we pay for this? And the last one was also about organizing Can you remind me organizing? I wrote down, but I forgot the last little bit.
Organizing medical services specifically for asylum seekers.
Oh yeah, for the asylum seekers, exactly. So maybe Adrienne, if you want to come, and the rest can already start to think where they want to come in.
Yeah, maybe I can say something about the first question. Like I agree with you about that the co-benefits are pretty obvious in principle, but I still see that it is not that easy in practice to actually convince other policymakers about the need to invest in health, or at least that is how it appears. So that's why, for example, as I spoke about the childhood house, that's something we are trying to investigate regarding as part of a childhood house evaluation as well. So why do stakeholders in different states, in some states it is the Ministry of Social Affairs that pays for those childhood houses. In other countries it's the justice system or the Justice Department that pays for those services, and we try to figure out what are the benefits out of the perspective of those different stakeholders. And I think it's really important to put more effort in understanding the perspective of each policymaker and how they can also use this in sort of advocating for their policies. Why is from a justice system the childhood house important, and why is it important from a healthcare point of view? Because they all have different benefits, I think.
They do. Okay, Tanya, would you like to come in on any of these? On the financing, or perhaps on the asylum seekers, or you have more to add on the making the case and how you do it in Portugal?
So I just going to say something. So one of the things someone put in the chat that we need what we need to assess more. I think assess is not, it's just the baseline, you know, it's just we have to assess in order to define the priorities, and afterwards to assess again after the intervention in order to see if we have an impact. And this is a problem. Sometimes we don't assess in the beginning and don't assess at the end. So we don't know the real impact that what we are doing, and we cannot measure the economic impact, for instance. So now in our studies, we are including more, you know, cool indicators like, for instance, the school success, or the percentage of youth that going to university, the migrant population that going for university, for instance, or if the economic and financial impact of workers that have mental health problems, you know. So it's important to include the socioeconomic and the financial issues in our studies, in order to prove that if we doing some prevention or intervention, we're going to have more money to invest in other things. So I think this is a language that we really need to come more with this. And the other thing, it's the financial. So normally we have money from government to do these studies, or from like private companies, depends, or social foundations. So that we have funding for this in several places. So the vulnerable children, they don't pay for these services. So these kind of projects, be the change and the ones that I show, the children don't pay for them because we have money from national sources or international sources, but it's not, you know, fixed. I think the big problem is we don't have a long-term perspective, you know. We are always doing things for the next year, and we really need to think in a medium long-term perspective.
Thank you. Yeah, maybe here you want to come in, Astrid, because I know that we've been thinking a lot about financing and the horizon of financing, and it's exactly what you say, Tanya. So, Astrid.
Yeah, I just wanted to stress what Tanya is saying, is that we saw initiatives in the policy brief that also started out with local funding and funding from, not necessarily public institutions, but also private organizations, and to showcase what the impact of these initiatives could be, and that they're now moving on to more national funding, like we're also seeing in Germany. So I think that's one approach that countries also can take to speed things up, and not necessarily going from top down all the time.
Yeah, I remember that was also one of the outcomes of the Swiss policy dialogue we held, that, why wait for the money to come? We can do already so much ourselves and then show that it's worth investing in. I don't know if Karen or Damiano want to come in on any of this. Karen or Damiano, just speak up if you would like to come in.
Well, maybe about the asylum seeker centers and the
Yes.
medical care, because I saw the question in the chat. Maybe the system in the Netherlands is quite unique. The public health services for youth are for free, and it's legally embedded. So our Ministry of Health will give money to the municipalities, and our organizations, our 25 regional public health services, are paid by the municipalities. But the tasks our doctors and nurses have to do, they are legally embedded. So we know what we have to do. And so we invite, during a circle of, from pregnancy till 18 years, we invite parents and their children about 15 till 20 times. And for asylum seeker centers, there's a different approach. And the finances are also differently coordinated. And I don't know exactly, but it's from the Ministry of, Safety and Justice, something like that.
Mm-hmm.
So there's a different money transfer. But we have, so because our tasks are legally embedded, it also is for every child in Holland, we have to do certain tasks. So we do them also for these two children.
Okay, so but then it sounds like maybe perhaps the fragmented funding can perhaps also sometimes be a bit of a barrier, but at least there is the right.
It is, because like a bus, it costs extra money, so we have to see how we get this money together to get the bus, the build, it has to be redone inside, and then we have to rent a chauffeur and whatever. So there's extra cost, and we have to see together how we can bring that up. It's not always easy, and it's not always...
I think that wraps it up quite nicely, that it's not always easy to find your way between all these different levels of government, fragmented systems, exactly. But let's remember that the children are central here. Yes, let's then now go over to Natasha for her final reflections, and maybe you will talk a little bit about, Natasha, about the children's health and well-being strategy that you're developing together with UNICEF. Natasha, over to you.
Thank you very much, Ewout. And indeed, let me start by saying that we have been seeing that in a number of areas, child health indicators have been stagnating. And typically in all countries, when you start to open this box, you will see that this is not some national average that just sort of falls equally across the board, but often it's the result of not reaching those people and those groups who are most vulnerable and most in need. And because of this, as WHO Euro, we have decided to work with UNICEF to bring child health and well-being once again to the forefront of the policy agenda. And as we embark on our European program of work, one of the pillars is healthy aging. But of course, we can't expect people to age well if we don't invest in early childhood development and in child physical and mental health and well-being. Partly, the renewal of the strategy will be to bring to the fore some areas which we already know to be important for years and where we just have been lagging behind in terms of implementation. So focusing on things such as breastfeeding, for example, on immunization with the added challenges of disinformation. And again, you start realizing that this is not taken up equally across society. But there are new areas that require us to have research to guide the appropriate policy actions too, because of emerging challenges. So we are taking forward to the forthcoming Regional Health Committee a strategy that focuses on 5 key areas. Firstly, investing strategically in child and adolescent health and well-being, because we need to do more and to do better. And I heard some people saying that there's too much short-termism and not enough understanding of the longer-term benefits. Secondly, it would be surprising to see how many children, even in the European region, still do not access the high-quality healthcare that they need, or that their families with young children actually face, for example, catastrophic health expenditure or impoverishing health expenditure to access the health services that their children would need. So we want to also make a clear statement over here that even when countries are really looking very carefully at what they are spending in terms of their healthcare systems, we should not move away from ensuring a good coverage of the appropriate benefits for child health. The third area, which is an area where we need to do far more, is protecting our children against the harmful effects of commercial goods and services. You all know very well the traditional ones that we work on: tobacco, unhealthy foods, but now we also have the digital determinants of health. And this, like foods, is a bit complex because you can't ban completely the use, because it's important for education, for example, also for social connectivity. But on the other hand, there are clear emerging signs of harm which need to be regulated. The fourth area is this multi-sectoral approach, which I think, particularly when we talk about children in vulnerable situations, this requires that we bring all the actors together, not least, for example, when we are talking about adverse childhood experiences, violence, but also more broadly, the need to link far better with, for example, education, sports, cultural activities, people responsible for ensuring that our children do have the ability to access green and blue spaces. And finally, as WHO, we come back to our core mandate, which is measuring and monitoring progress for accountability. This mutual accountability, member states and WHO holding ourselves accountable to make progress in this area. And over here, we use, again, many of the existing indicators that have served us well. When we look at mortality and morbidity indicators, when we look at special data collections, such as the Health Behavior in School Children Survey, but we also need to ensure that we are measuring and monitoring what really matters. And this means that we may need to be brave and bold enough to also come up with new, meaningful indicators to track areas that are emerging as important to child health. So we would encourage you to link with your national authorities. And we hope that as a result of the adoption, fingers crossed, of this strategy, member states will once again find a renewed impetus to take up child health, to renew, revise, revisit, or come up with new strategies for addressing the health and well-being of children and adolescents across our region. And I believe, Erika, that you have posted some links to useful material in the chat. So thank you also for giving us this opportunity to talk about this important upcoming strategy for the children in Europe. Back to you, Eva.
Thank you very much, Natasha. And I think that she reflected many of the things that we talked about today in the strategy, and that's really good to see. And we hope that this will be adopted as planned, and hope that we also give a little bit of a piece of the puzzle with this work that we produce together. So thank you very much. Thank you very much to all the panelists. I'm closing the seminar and already telling you that also next week there will be a seminar on closing the digital skills gap for the European health and care workforce. So you're all invited to that. And until then, have a great week, and we'll see you next week. Thank you very much for joining.